Nevertheless, I'm like the redheaded stepchild talking about coronary intraperipheral cores. Proctor and speak for a couple of companies, none germane to the topic or content of this talk. So if we look at the definition of coronary perforation, it's extravasation of contrast media or blood from a coronary artery during a percutaneous intervention. And if we separate it into anatomical spaces, we can look at proximal remit vessel, which may have a more profound and clinically significant sequelae, versus a distal vessel, which may have a much more benign course. And there's multiple classifications, and there's also one from Sinai. So the Keeney classification, Lookstein, I guess you guys have a few perforations up there as well. But the most popular one is the Steve Ellis classification, developed in 1994 into basically 4 categories, type 1, 2, 3, and 3 cavity spilling. And those escalate to the amount of severity of those perforations. And if you look at the ones, it's typically into the adventitial space. You go a little further into tissue. You may have an impending bad thing happen for 2. Type 1s are pretty safe. You get to type 3s, then you have at least a 1 millimeter leak. And if it spills into the appropriate cavity where you would want to put blood, then it's a very safe, benign course where you can sit on it. But most of the time, that does not necessarily happen in the type 3 cavity spilling. They spill into the pericardial space, and they become some type of emergency. Now, if you look at this chart, you can see, and I don't think I have a pointer anywhere up here, but if you look at coronary perforation, you can see that there's a host of complications that can occur in coronary arteries. All of these complications are an extremely small, less than 1% number. However, none of these complications have the clinical sequelae of coronary perforation, and that is up to 50% cardiac tamponade, up to 12% chance of emergency surgery, and death in roughly 8% of these. And if you look at across these series of publications, you can see a very low incidence of perforation, but you can see a very high incidence of death, CABG, and cardiac tamponade. There are certain angiographic risk factors that are connected to a higher likelihood of perforation, and there's also patient-related risk factors, which I also will not regurgitate, that make perforation in coronaries much more likely, and it's very similar in the periphery. The diagnosis is made with high index of suspicion. You have to recognize that not all perforations occur immediately. You sometimes have to wait, and progressive hypotension after you send a patient back to the room means that you need to be aware. There are a host of approaches to perforation, bypass surgery, the covered stents, and all of the different injectables that these guys have so elegantly talked about. You have to know all your tools for perforation. You have to know how to use the Papyrus and the JOMED. Both of these are IDE devices, and you have to do this under research protocols. You have to know how to use all your injectables, et cetera. I will skip distal perforation. Initial management, you have to determine if these are stable hemodynamically or not, and if they're not, then you have to go down through your laundry list of hemodynamic instability to throw the kitchen sink at them, and this is the kitchen sink, and you determine it whether you have perforations in straight vessels, distal vessels, or whether you have bifurcations involved, et cetera, as to what type of tools you pull out of your toolbox. So I want to present to you a case, and this lady must have known this conference was coming up. I did this case last Friday. They never happened Monday through Thursday. She's 83 years old, in STEMI 3 weeks prior. I treated her medically. What happened? I treated her medically. I sent her to a cardiothoracic surgeon who turned her down for multiple reasons. You'll see she had end-stage renal disease, hypertension, COPD, chronic anemia. She had bilateral carotid stenosis, asymptomatic. She had a GI bleed about a month before I saw her for the STEMI. She'd been transfused with 4 units of blood. So, not showing you the diagnostic nor the right coronary artery. She has an ostial LAD lesion there. It was also in the left main. I proceeded to wire both the circ because there's an OM lesion I will show you. A balloon inflated. You see the calcified aorta. She has a porcelain aorta. I put a stent in the LAD, back into the left main because of vessel mismatch, which you see there in the left main. I used a high-pressure 4x8 inflation. I then removed my wire from the circumflex coronary artery, placed it through the stent struts, and did a kissing, simultaneous kissing balloon. These were 3-millimeter balloons, 16 atmospheres, and my best guess is after this image is where I perforated the vessel, but you're not going to see it. So after I did that, thinking that I'm through, look at this tortuous circumflex coronary artery going off to the left. Very difficult coming from the left main into that, but nevertheless, you see my crossing catheter down, crossing the very critical lesion in a bifurcating obtuse marginal. I negotiated that, put an orbital atherectomy catheter in it, never burred proximal, where I'm going to show you this perforation. Did a balloon inflation of that. I then performed a drug-eluting stent in that. I shut off my ongoing circ, and there you see the perforation. So this lady was fairly hemodynamically stable. So you balloon tamponade these vessels. You can reverse your ACTs, but you can't do it emergently. You have to do it gently, and you have to reverse it back because you're still going to have indwelling equipment. And we've all been there, done that on a non-anticoagulated patient, and had, you don't want to clot off your whole coronary tree. So after I reversed the ACT, I went up and down with perfusion, with occlusion balloons for roughly 45 minutes, 10 minutes here, 5 minutes there, changed balloon sizes, and finally bailed out through this tortuous circumflex, which doesn't appear tortuous here because it's straightened out with a guideliner and a Graftmaster stent. I employed my Graftmaster stent, performed high-pressure inflations, which you do with all of these, and took what I thought would be my final follow-up angiography. But again, you see I've even made the perforation worse. And the reason is because of this proximal, calcified, tortuous circumflex artery that I keep shoving junk through to fix a bifurcating obtuse marginal. Eventually realizing that, I placed a guideliner back in, I placed a second Graftmaster stent, and I got a beautiful final result, occluding the perforation, and the lady did well. And I didn't fix the right coronary artery. So with that, in conclusions, you have to prepare and focus on prevention, and you have to recognize complications of coronary angiography, and this is the worst one. You have to understand your toolbox for managing complications. You avoid full reversal of anticoagulation. You need to send your typing screens before you take patients to a cath lab. You need to diagnose long angiography runs carefully, which I looked at these 100 times after I finished the case, and I still didn't see the perforation. Don't be afraid to call the cavalry if you need it. This lady was hemodynamically stable and didn't need it. And always tell the patient exactly what happened in layman's terms when you perforate vessels. Thank you.